share lang ng screen, Doc DJ. Thank you very much everyone for your invitation, especially ng Philippine College of Occupational Medicine. And of course, Dr. Rona, congratulations in this Sabado night's activity. Uh, can you can you see my slides na po ba? Chat, Doc DJ?
Yes, Doc. Okay.
Yes, Doc. Yes.
Good. Okay. Okay. A pleasant evening to everyone. Occupational allergic rhinitis or occupational rhinitis or OR is a yun po i-share ko tonight. This is a disease of emerging relevance. However, it has received a little attention in comparison to occupational asthma or to allergic rhinitis. So nahuhuli siya compared with the asthma or the AR. So itong occupational rhinitis ang i-share ko for this evening. So this presentation and sharing will cover the main items of occupational rhinitis, including the epidemiology, diagnosis, management. I will also touch on the socioeconomic impact, some preventive strategies, and we'll also touch on some medical legal issues. There is no currently there is no consensus on the definition and classification of occupational rhinitis. In addition, diagnostic procedures as well as strategies for the management of subjects with occupational rhinitis remain poorly standardized. So wala pa pong consensus dyan. This is primarily important point as an accurate and early recognition of occupational rhinitis in surveillance program is not only important per se, but it's also useful in the prevention and early diagnosis of occupational asthma. Again, this is integral in the role of the Occupational Safety and Health Committee of the hospital or your workplace, and this is mandated by Republic Act 11058 or the Act strengthening compliance with occupational safety and health standards and providing penalties for the violation thereof. For this short presentation and sharing, we will be defining very briefly occupational allergy as well as occupational rhinitis. We will use the occupational allergy model in the approach of the occupational rhinitis, and then how do we diagnose AR and OR, the specific management following the area classifications and treatment options, and then there will be about 9 discussion points in this and some few studies as I share some of the slides. But before we proceed in defining occupational rhinitis, we have to understand first what is work-related rhinitis. So magkaiba po, no? Work-related rhinitis, ito po yan. Work-related rhinitis may be classified as occupational rhinitis, that's the one on your left, or it could be work-exacerbated rhinitis. So we have to understand that these are two different concepts. When we say work-exacerbated rhinitis, this is when your rhinitis symptoms are worsened by non-specific exposures in the work environment among your workers with pre-existing allergic or non-allergic rhinitis. On the other hand, when we say occupational rhinitis, we say that these are directly caused by a specific substance encountered in the workplace or in the work environment. So we further mentioned that occupational rhinitis, makikita nyo po dyan, there's an arrow below it. Uh, um, Occupational rhinitis can be allergic, which is caused by IgE-mediated sensitization, or yung isa, RUDS, or the reactive upper airway dysfunction syndrome, which are acute exposure to a chemical irritant or sometimes combustion products. Okay. Occupational rhinitis is an inflammatory disease of the nose, of course, which is characterized by intermittent or persistent symptoms like nasal congestion, sneezing, rhinorrhea, itching, variable nasal airflow limitation, or sometimes with or without hypersecretion. And all of these are attributable to a particular work environment and not to a stimuli encountered outside the workplace. Okay? So meron na po siya dating yung symptoms niya are attributable pag pumapasok siya sa kanyang work area. Okay? So dapat maintindihan natin kung ano yung occupational rhinitis. Okay? OR is a work-related rhinitis, and it could be distinguished into the first arises out of causes and conditions attributable to a particular work environment or pre-existing or concurrent rhinitis exacerbated by workplace exposure. As mentioned kanina, yung RUDS or the upper reactive upper airway dysfunction syndrome, ito po yung isa, acute absence of latency, and there's a causal relationship or the temporal association between exposure to unusually high levels of irritants and the development of rhinitis. There's also such thing as irritant-induced OR. Pag sinabi po natin yan, these subjects are repeatedly exposed to low concentration of irritants like first.
Kaya po, hiberbirok na gaminti matnagama.
There's also a variety of occupational exposures have been associated with rhinitis symptoms. There's also such thing as corrosive OR. This is the most severe form of irritant-induced OR, and it's characterized by, please take note, this is a permanent inflammation of the nasal mucosa. So you can see there, you can observe ulcers and septal perforations. And this develops after exposure to high concentrations of irritating and soluble chemicals. So also we have to distinguish at this point what is HMW and from LMW. You can see here HMW, these are the high molecular weight agents, and the LMW or the low molecular weight agents. So itong HMW proteins and low molecular weight chemicals, they can cause occupational asthma, although few studies have thoroughly compared the clinical, physiological, and inflammatory patterns associated with these different types of agents. So naka-differentiate naman dyan. It has been shown that occupational asthma caused by the low molecular weight agents may be more severe than that caused by the high molecular weight agents. This study did not find any association that might explain why occupational asthma or occupational rhinitis is more severe when caused by low molecular weight agents. A plausible hypothesis is that these agents may have different mechanisms of action that may trigger different responses in terms of both inflammation and bronchial hyperresponsiveness, so thus altering the degree of severity. As mentioned earlier, if we say HMW, that's more than 5 kilodaltons, and then if it's less, that's the low molecular weight agents. Yung more than, that's a biological substance versus the low molecular, those are the synthetics chemicals. Nakalagay po dyan yung examples. Occupational rhinitis, kita nyo po dyan, the survey of workforces exposed to sensitizing agents indicate that occupational rhinitis is 2 to 4 times more common than occupational asthma. Although the contribution of workplace exposures to the general burden of the rhinitis remains unknown. The level of exposure is still the most important determinant of IG-mediated sensitization to occupational agents and to occupational rhinitis. And you can see here that atopy is a risk factor for the development of IgE-mediated sensitization to high molecular weight agents, but the association with clinical occupational rhinitis caused by the HMW agents is still less substantiated. This still needs further studies. Prevalence in the workforce, of course, varies depending on the sensitizing agent. Depende kung saan nagtatrabaho yung worker. Kung exposed siya sa HMW or sa LMW. So you can see here 2 to 87% for HMW and 3 to 48% LMW. As mentioned earlier, depende kung saan siya exposed and magkakaiba pa rin ang mechanisms of these agents. Okay? Kahit HMW yan, magkakaiba pa rin siya. No? Walang standard na sinusunod kung HMW yan or LMW. Kaya makikita niyo po rito yung prevalence is halos pareho. Okay? So the relationship with the occupational asthma. So majority of patients diagnosed with occupational asthma also suffer of occupational rhinitis, which most often precedes the development of occupational asthma, especially when high molecular weight agents are involved. Occupational rhinitis is associated with an increased risk of asthma, although the proportion of subjects with occupational rhinitis who will develop occupational asthma still remains uncertain. Hindi natin alam kung ilan ang magkakaroon ng occupational rhinitis or occupational asthma. There's increasing evidence that the work environment contributes significantly to the burden of rhinitis and asthma worldwide. So, negatively affecting the quality of life, workability, and socioeconomic status. So, as mentioned earlier, mas common po ang OR 2 to 4 times than occupational asthma. This is a 2010 study. Occupational rhinitis, you can see here that IG-mediated, yan po yung mga biologic agents, di ba? High molecular weight agents and some low molecular weight agents. Yung mga non-IG-mediated, ito po yung mga synthetic na low molecular weight agents. Okay? Mechanism for the IG-mediated is of course proven IG-mediated mechanism, and then the non-IgE, they act as haptens, and then but the mechanism is not yet fully understood. When we go to occupational medicine, so we have to do investigation and diagnostic approach. So questionnaires and clinical history have a low specificity for diagnosing occupational rhinitis. So anong pwedeng gawin? So immunological tests like skin prick and specific IgE antibodies are sensitive but not specific tool for diagnosing occupational rhinitis caused by the biologic agents and some low molecular weight agents. In the presence of work-related rhinitis symptoms, we have to use objective assessments like nasal provocation challenges in the laboratory or at the workplace. Ito po ang strongly recommended. However, it's still a challenge, especially here in the Philippines. So complete avoidance of exposure to the agent causing allergic OR should still be recommended as the safest and most effective therapeutic option. So I emphasize po natin yan, complete avoidance. So when complete elimination of the causal exposure is expected to induce important adverse socioeconomic consequences, reduction of exposure with relevant pharmacotherapy may be considered an alternative approach, especially in workers with a lower risk of developing asthma. So these workers should, however, benefit from close medical surveillance aimed at an early detection of occupational allergy. So it's also nice that if you have a big workplace, dapat meron po kayong employees clinic. Okay? The socioeconomic impact of occupational rhinitis still remains unknown, but it is likely to be substantial in terms of work productivity, as can be extrapolated from data available for allergic rhinitis in general. Primary prevention strategies should focus on reducing exposure to potentially sensitizing agents. So kung yung worker po ninyo nag-work sa isang area na may high molecular weight or low molecular weight agents, so dapat you have to provide kung hindi nyo po maggawa ng chance to do engineering controls or admin controls, siguro bigyan nyo na lang ng appropriate na PPE. Identification and exclusion of susceptible workers is not efficient, particularly when the marker of susceptibility had to be prevalent in the general population. Part of the prevention strategy also is as an occupational safety and health officer, you have to do surveillance programs which are aimed at an early identification of occupational rhinitis, which includes periodic administration of questionnaires. So, dapat lagi yung tinatanong yung mga empleyado po ninyo kung merong exposure doon or ano bang common ngayon, ventilation problem sa kanilang workplace. So you have to do that. Lagi nyo po dapat silang binibisita. Otherwise, if available, you can do immunological tests. Surveillance of workers should focus on the first 2 to 5 years after entering exposure. Sometimes sisisihin po yung workplace for a future chronic problem. So dapat meron po tayong maayos na records nung pumasok pa lang yung worker. Okay, the possibility of occupational allergy or occupational asthma should be carefully evaluated in all workers with occupational rhinitis. Very important is the medical legal aspect. So workers with occupational rhinitis should theoretically be considered impaired on a permanent basis for the job that caused the condition, as well as jobs with similar exposures. Allergies, genetics, diba? You have it for life. So when your worker has occupational rhinitis, you can consider that impairment as permanent. Okay. So compensation of occupational rhinitis should aim at providing incentives to accommodate workers to unexposed jobs, and of course offering rehab programs to minimize the adverse socioeconomic consequences of the disease. As mentioned earlier, there's no standards on occupational rhinitis, so we'll be using the allergic rhinitis model in managing the occupational rhinitis. Okay, so allergic rhinitis we know is caused by the interplay of genetics and the environment. So a knowledge also of the hygiene hypothesis would be very helpful for future strategies. I've mentioned early in my lecture that I will be sharing to you some 9 discussion points. So, sasagutin po natin yung 9 points na yan. Okay? Discussion point number 1. How much percentage of your total patients have you diagnosed with AR in the past week? So, we will be using the study this by Navarro Luxin, who is also the past president of the ENT Society. So, we used 100 generalists and 100 specialists. The median number of patients seen per week. Marami po ang nakikita ng generalist as compared to the specialist. Median number of patients with allergic rhinitis seen per week, 15 for the generalist and 20 for the specialist. The impact of this is seen in this data. We study allergic rhinitis alone or with asthma associated with an increased risk of sickness and absences. So you can see here the number of sick days per year for respondents, from 14.6 days to 24 days per year. So kung may sakit po yung empleyado po ninyo, may rhinitis po siya, or may asthma or both, you expect this worker to be absent ganyan karami araw, 17 to 24 days per year. Number 2, discussion point number 2, what is your first step in the diagnosis of AR? So, paano mo malalaman kung may AR yung pasyente? So, since the inflammatory reaction occurs mainly in the nasal symptoms, the patient should have 2 or more of the following symptoms for more than an hour on most days. We cannot label any worker with allergic rhinitis kung bigla lang siyang sinipon for 10 minutes per day. So, ang sabi po natin with these guidelines, it's an old guidelines, 2 or more symptoms more than 1 hour on most days. Para hindi nyo po malimutan, I share to you the SLIDO. Sneezing, lacrimation, itching, nasal discharge, nasal obstruction with or without conjunctivitis. Okay, so kung meron po yan, we can label the worker or the employee as AR. Okay. Memorize niyo po ba to? Papadrawing ko po yan mamaya. So symptoms usually not associated with allergic rhinitis. So have to be referred to an ENT. Unilateral symptoms, isang ilong lang ang sinisipon, pwede bang magkaroon ng allergy yung right side lang? So you have to refer that to an ENT. Nasal obstruction without other symptoms, mucopurulence, post-nasal drip with thick mucus and or no anterior rhinorrhea. There's also pain, mabigat yung mukha, masakit yung mukha pag nag-lean forward. Sometimes they have nose bleeding and sometimes anosmia dahil barado yung ilong. Supportive clinical information needed in the diagnosis of AR. So you have to check for history of atopy, family history of atopy, symptoms exacerbated by allergen exposures. Very common po to, symptoms in the morning upon waking up or yung matutulog pa lang pagpasok sa bedroom, may symptoms na. And then of course, meron po tayong visual analog scale quantifying the severity of rhinitis symptoms. This is the VAS. How bothersome are your symptoms of rhinitis? This is very helpful to guide the doctor in the appropriate management and monitoring of intervention outcomes. Meron na po kasi bagong algorithm now. It's being used in Germany. This is self-treatment. They have an app for allergic rhinitis. So depende kung nagbabago yung VAS score, mag-change yung treatment ng pasyente. So ginagamit na po ito compared nung ginawa ito noong 2015. Ngayon, nagagamit na siya. So this is the ARIA classification. We take note of the rule of fours, di ba? 4 days, 4 weeks, more than ba siya or less than. So this classification guides the clinician with the treatment and management of allergic rhinitis. So you can label them as intermittent, persistent, mild, or moderate and severe, depending on the number of their symptoms and the duration. Number 3 na po tayo. How much percentage of your patients have you diagnosed with AR related to work in the past week? So sa both groups, generalists and specialists reported treating the same number of patients with mild AR. Specialists treated twice the number of patients with moderate to severe AR compared to generalists. So, meron at meron yan sa ating clinic. Number 4, what physical examination findings do you expect to see in patients with AR or OR? Ano po kaya? So, para makita po natin, you have to perform anterior rhinoscopy. You have to look inside the nose. Kahit po sa panahon ng pandemya, sinisilip pa rin po ng ENT yan. So this maneuver must be performed to support the diagnosis of allergic rhinitis and other nasal pathology. So you have to take note. Turbinates. Ano ba itsura? Pale gray ba yan? Dull red or erythematous? The turbinates should also be boggy. Sometimes you can observe their minimal to profuse watery to mucoid nasal discharge. So kailangan mo silipin para malaman mo kung totoong sinisipon or totoong may allergic rhinitis. So this is a nasal endoscopy findings of a pale and boggy turbinates. You can see there the turbinate is already touching the nasal septum. So mapula siya, tapos watery yung discharge. Sometimes greenish or yellowish na rin po siya dyan. So I took this from the PSOH and SCPG on AR of 2015. So we have to do a complete ENT examination in our patients with AR. Papakita ko po yan, mga picture ng high arch palate, open mouth posture, Denny Morgan lines, nasal crease, and sometimes you also look inside the ear to observe for medial ear effusion. Please take note of the acuteness of the palatal midline. So makikita niyo po rito yung upper lip. And of course, that's the nose. This is the upper jaw. That's the dental arc. So you can see here the normal palate compared to the severe arching. Okay, ang taas na nung palatal midline po niya. So you can see here you can observe here the acuteness of the palatal midline. Okay? Ano pa po ibang symptoms na nasabi ko po sa inyo? Mouth breathing can affect also the entire system. So mouth breathing can particularly affect the facial muscles and the bones of a growing child, especially kung bata po yan, lagi na po siya nagma-mouth breathing, yung dentofacial growth niya will be affected. So this can cause facial deformities that are often too severe for orthodontics to correct. So sometimes these individuals may require jaw surgery later in life. So makikita niyo po dyan, the mandibles is retruded. Okay? Nakapasok. They also have snoring. So quality of life nila and their sleep is also very poor. Denny Morgan lines are also known as Denny Morgan folds or infraorbital fold. This is a fold or line in the skin below the lower eyelid. So it can be genetic, it can be ethnic, but there was a study to occur that this occur in 25% with patients with atopic derm. The presence of these Nelly Morgan lines can be used as a diagnostic markers for allergy. Mataas po ang kanyang sensitivity and specificity rate. So it could be a diagnostic significance in atopic dermatitis. So titingnan mo pa lang yung pasyente, di mo pa sinisilip yung ilong, meron ka na sigurong initial diagnosis. Just looking at the Denny Morgan lines. Nasal crease. Bato allergic salute, you can see there the nasal crease. Laging makati yung ilong, may sipon, kaya nagkakaroon ng linya sa kanyang nasal dorsum. Okay. And then you also have to look inside the ear. You should have an otoscope. So you can see here a red tympanic membrane. You can see there the air fluid level. This is mas clear po dito sa right side. You can see there no, parang may kulay iced tea compared with the normal eardrum. You can see there, di ba may cone of light? You cannot observe the cone of light in the pictures above. May distorted yung cone of light. So kung meron ganyan, and then you can see an air fluid level, so baka meron siyang middle ear effusion, which could be interpreted na baka meron siyang allergic rhinitis or even allergic otitis. Number 5, which diagnostic procedure do you routinely administer to your patients to determine the presence of AR? Ano po kaya? So again, both groups agree that diagnostic procedures are not routinely done among patients with AR. Kasi clinically, you can already diagnose allergic rhinitis. Okay, so both groups agree. Hindi kailangan ng diagnostic test. Allergic workup, these are not routinely performed. Nasal endoscopy, skin test, IgE test, nasal provocation test. But later I will share to you a slide kung kailan kailangan mga to. Indications for allergy workup, questionable diagnosis exist. Hindi po gumagaling, binigyan mo na po lahat ng options for pharma treatment, di pa rin. Can I control the symptoms, multiple target organ involvement, when immunotherapy is considered, and patients with suspected local allergic rhinitis. So this is practiced in some first world countries where technology and expertise may be available with costs paid by their health insurance. This may not be the case in the Philippines. Okay, okay, we're good. Discussion point number 6. What are your first line drugs to manage patients with mild intermittent allergic rhinitis? Ano po kaya? So you can see here, yung pinakamarami nasa left side, monotherapy, specifically an oral second-gen antihistamine. We give that for about 7 days muna. Is the preferred first-line treatment for mild allergic rhinitis by both specialists and generalists. And this is consistent with the ARIA guidelines. So prevention of occupational allergic rhinitis again is controlling exposure at the workplace. That's still the most effective, diba? Avoidance, ang pinaka-effective prevention. Then of course, identification of susceptible workers, especially history of atopy, especially in their family history, and then of course bronchial hyperresponsiveness. This is which increases the risk of developing asthma. Medical surveillance of workers at risk, kahit mild po yan, again, uh, you have to do periodic administration of questionnaires to detect work-related symptoms. Makikita nyo po dyan kung ano po yung mga exposures nila at their workplace. Occupational agents, early referral of symptomatic or sensitized workers for further medical or ENT assessment, investigation of possible asthma in all workers with confirmed occupational rhinitis. Number 7, what are your first line drugs to manage patients this time moderate to severe intermittent or persistent allergic rhinitis? Yung kanina mild, di ba? So ito po yung moderate to severe. Ano po? So for the management of moderate to severe AR, both groups, the specialist and the generalist, are equally divided among those who use monotherapy and those who prefer combination treatment. So the preferred monotherapy of both groups is an intranasal corticosteroids given for at least 1 month. Personally, I give it mas matagal po. For those who use combination treatment, half of them prescribe an oral second generation antihistamine with anti-leukotriene. The rest of the group use intranasal corticosteroids, oral second gen antihistamine, and anti-leukotrienes. So again, these protocols are still consistent with the ARIA recommendations for moderate to severe allergic rhinitis. Reason why doctors prescribe these drugs. So both groups agree that the reason for drug prescription is still efficacy. So nag-agree po tayo dyan. 92% and 67% efficacy po. And with regards to patient treatment compliance, both clients of generalists and specialists, that's 93% and 76% respectively, says that the cost of drugs or the cost of treatment is still the main reason for compliance. So dapat affordable po at efficient ang ating gamot na ibibigay sa ating mga workers. For moderate to severe, kita nyo po yung red arrows. For moderate to severe AR, we give intranasal corticosteroids with H1 blocker or leukotriene antagonist, and then we check that response for 2 to 4 weeks, then we treat accordingly thereafter. As mentioned earlier, di ba may VAS score? So, depende kung ano yung score ng pasyente. If it's less than 5 na yung symptoms niya, you can downgrade the treatment. If it's persistent, you upgrade the treatment. Number 8 na po tayo. What do you use as adjunctive treatment for patients with AR? Ano po sa tingin ninyo ang adjunctive treatment for patients with allergic rhinitis? So, nasal irrigation. In AR, this is systematic review and meta-analysis. Studies show that the use of saline irrigation results in significant decrease in the nasal symptom scores, better mucociliary clearance. Siyempre, nawawash yung crusting sa loob ng ilong, and of course, it would results to improved quality of life. Nasal saline irrigation also noted to be it's cheaper, it's economical, so it's easy to use and it's safe for long-term use. But please take note, this is only an adjunctive treatment option. Number 9, when do you refer AR for immunotherapy? And then is there a role for surgery in the management of allergic rhinitis? Immunotherapy may be used in the following patients. So, yung mga hindi po gumaling sa avoidance therapy, hindi nila ma-avoid ang allergen exposure, at hindi nila kayang uminom ng gamot, pharmacotherapy. They cannot tolerate yung drugs. Those who are chronically exposed to allergens, patients with rhinitis and symptoms from the lower airways during peak allergen exposure. So allergen immunotherapy may prevent the development of new allergen sensitization and reduce the risk for future development of asthma in patients with allergic rhinitis. So you can refer that for immunotherapy. We have allergologists already here in Baguio. So refer natin sa kanila. How about surgery? There's no surgical treatment for allergic rhinitis, but they may be indicated in the management of comorbid conditions tulad ng laging barado yung ilong, persistence of the obstruction. Kasi pag sinilip natin yung ilong, malaki na pala yung inferior turning. There's also septal deviation or sometimes there's hypertrophic adenoids or adenoidal hyperplasia. Then those developing chronic rhinosinusitis, the complication. You have to refer them for surgical treatment. Allergic rhinitis or occupational rhinitis may be diagnosed primarily by history and physical examinations. We don't need diagnostic test. Please look inside the nose para makita niyo po yung um, physical findings, especially of the turbinates and the lining of the nasal mucosa. Diagnostic procedures are not routinely used. Specific allergic rhinitis management depends on the temporal profile and severity of the disease. Again, avoidance to exposure and pharmacotherapy are the primary treatment modalities, and immunotherapy and surgery are reserved only for some indications that I've shared to you. So again, I have shared to you OA and occupational rhinitis. Nakita po natin how to do the history, yung SLIDO, and then what to look inside the nose, physical examination. I've shared to you some specific allergic rhinitis management and following the area guidelines and some treatment options. And then we discussed 9 discussion points and some studies. That's my last slide. Thank you again. Thank you for the invitation in this Sabado night's activity of PCOMs. Maraming salamat po at magandang gabi po sa inyo lahat.
Sure. Good evening once again, Doc Tong. Hello po. Good evening. We would like to thank you for healing us with your presence in this lecture. And before we go to our question and answer, we would like to acknowledge the presence of our president, our national president, Dr. Ria Fajardo, and our other PCOM officers. Welcome to our lecture. And now we start with our Q&A. So may we ask if you have questions, maybe ask the audience. If you have questions, you can type them in our chat box. Wala pa yata po. Medyo wala pa tayong questions, Doc. Pero actually, we have anonymous questions. I mean, questions from anonymous doctors na sinend lang. So, our first question, Doc, will be, in your practice, Doc Tong, usually how many days does a patient have to go on sick leave due to occupational rhinitis?
Thank you for that question. How many days for sick leave? We give the medications for about a week, sometimes with antibiotics. So until after the symptoms has disappeared, kasi kailangan nilang bumalik on the third day, on the seventh day. No more symptoms, I think they can go back to work. Physically fit na sila. Otherwise, kung may symptoms pa yan, because of the stigma of COVID, I think they're better to stay at home and isolate muna themselves. So, sa aking practice, ano muna sila, They come back on the third day and then on the seventh day. I can always issue another medical certificate. Yeah.
Alam na natin sa practice, Doc. So we actually have a lot of cases today, no, Doc, when it comes to our employees. We have cases of usually respiratory talaga. So with the advent of this pandemic din po, no? So thank you, Doc, for that answer. We have another question from another anonymous participant. So, Doc, is there a best screening method for occupational rhinitis other than clinical examination?
Screening method. Thank you for the question. For as mentioned po kanina, when you have a new worker, it's nice to have them do the complete physical examination para po ma-document yung baseline. And then still symptomatic, um, eh, signs and symptoms lang po tayo sa allergic rhinitis. For occupational rhinitis, we also follow the allergic rhinitis model. So we just document the signs and symptoms, and if you have a nasal speculum or a nasal endoscope, siguro it's nice to document also your findings para magkaroon ng baseline. I think siguro yun na lang muna. Especially if you're taking care of a big company. Kasi pwede kang balikan soon, nagkaroon ka ng nasal polyp, but we can always refer to our allergologist para ma-identify kung anong uh, allergens sila allergic. Okay. Sa ngayon kasi wala pa. Most of the time it's Doc DJ, it's irritation lang sila. And then we label them as allergic rhinitis if their signs and symptoms follow yung ating standards from the area guidelines. Doc DJ.
Have you noted COVID po?
Noted an increase in the rhinitis. Have you noted an increase in allergic rhinitis after COVID? I think parang ano siya eh. I would look at it as parang mas babalik rin ko siya. Baka mas maraming COVID doon sa mga may comorbid like allergic rhinitis. So, siguro pag immediately after COVID, pag pagaling ka na, siguro kung na lang yun. Siguro, probably hyperreactive na lang ang ating mga airway, kaya may sipon or may post-nasal drip. But not really an allergic rhinitis. But I would agree, Doc Rhea, baka rhinitis lang yun, not non-allergic siguro. On the other hand, if you have allergic rhinitis or asthma, siguro mas prone ka to have this COVID infection. Parang titignan ko siya as the other way around. I hope na sagot kita, Doc Rhea. Thank you, Doc DJ.
Thank you, Doc, for that answer. I hope na po, mukhang nasagot naman po ni po yung question ni Doc Ria. So, I think we are done with the question and answer, but we are urging if we have other questions po from our doctors or our participants, they can actually chat them and chat.
Dr. Alimlim, I think, is raising her hand.
Invite. Mukhang, saan ba si Doctor? Wait lang, Doc. Para Ray? Mami Ray?
Yes, yes.
Yeah.
Kami dalawa.
Doc
Kami
Leo?
dalawa ni Dr. sa isang gadget kasi hindi siya makapasok. Si Dr. Leo ang magtanong.
Na-miss ko lang si Dr. Tong kaya ako nag-question. Actually, first a short comment, no? From the point of view of occupational medicine, in the approach of we've talked about, well, Tong mentioned about avoidance, no? And the the strategy employed by occupational medicine is first the engineering control, where we try to avoid exposure to the identified allergen, like if there are designs that can be done to avoid exposure. For example, the use of a wet method in procedures, like in grinding. Well, that's an engineering control. No? Administrative, if we can schedule those who are prone to allergies um, from a schedule that can avoid getting them exposed, like outdoor exposure to pollens. No? Then, and then the third strategy is, of course, the personal protective equipments. No? The use of mask and other PPEs, respiratory PPEs. No? Now my question. No? uh, Dr. Tong, we focus this time on occupational allergy and occupational rhinitis. No? What percentage? It looks like a small part, a fraction of allergic rhinitis eventually develop asthma. No? And I'm asking this question to because the asthmatic episode will be more serious. No? So to prevent the onset of a more serious asthma, I think it's very important for us to uh, initially manage, no, allergic rhinitis. No? So, what percentage of allergic rhinitis eventually develop bronchial asthma? Do you have a figure or a study on this?
For the question, sir, for pero hindi po siya occupational, sir. We don't have really the number for occupational rhinitis, sir. Kasi it's, it would be nice sana kung may study ang kung ano, sir. Occupation,
Yeah,
labor, under labor po sana, Department of Labor, no, sana.
yeah,
Uh,
yeah. That's right. No.
opo.
Actually, the arm of Department of Labor that does research is OSHC, Occupational Safety and Health Center. But of course, if there are regions or areas with this kind of hazard, maybe OSHC can fund or even sponsor research on this area. No? So I think that could be a good collaboration with PCOM, Baguio Benguet chapter, no?
Yeah.
ENT.
And
Sir,
of
yung
course ENT as a partner specialty. No?
sir, for ano po, we in ENT, sir, we talk of United Airways. So if you have allergic rhinitis, you can have bronchial asthma, and if you have bronchial asthma, you can also have allergic rhinitis. So you can have both, or you can have AR alone or bronchial asthma alone. So one can trigger the other. Ganun po siya, sir. So parang if you have bronchial asthma, sir, sabi po around 30 plus percent can have allergic rhinitis. Ganun din po, the other way around. Parang one out of can have the other. Parang ganun po. But that's not, hindi, wala po tayong numbers sa occupational, sir.
Yeah, yeah.
Similar po, sir. I think baka,
So if that's the case, therefore maybe it's better to treat them as if it's systemic, no? Because they can it can go either forward or backward. So maybe a systemic approach would address both the issues, both allergic rhinitis and asthma together. Well, thank you, Dr. No?
Thank you.
thank you po, sir. And to, in the same line of thought po, when we say allergy po, tama po, ano, yung elimination first, di ba? If you
Yeah,
can
yeah,
eliminate, you can avoid it better. Then of course, the admin engineering control. Otherwise, sir, pipila
yeah,
tayo.
yeah. Salamat. Huh? Thank you.
Thank you, Tom.
Thank you po, Doc DJ.
Thank you, Mommy Ray and Doc Leo. Thank you for that. Um, so so due to the interest of time, we would like to thank you, Doc Tong, Doc Untalana for giving us the opportunity or for giving us this lecture for tonight. So, share screen ako. Sorry. So so to present our certificate, Dr. Tong,